Well, first I want to thank all 30 people, that includes Chris and I, for being hardcore. And we're going to, after 12 noon on Eastern Standard Time on a pre-Thanksgiving, sit here and critically look at Sbirt, Screening, Brief Intervention, Referral, or Treatment. So thank you all for following through and participating with us on this webinar. Before, I'm sure some of you have pies in the oven and other preparations underway. Before I go ahead, and I wanted to introduce a little about the Northeast ATTC's experience with Sbirt and IRETA, which is the parent organization for the Addiction Technology Transfer Center Northeast region. I wanted to just reinforce something that was on your registration forms. As an ATTC, if you guys are loyal webinar followers and also on our listserv, hopefully you've been to some of our trainings, you know we represent the states of New York and Pennsylvania, and that New York has recently released some Medicaid standards for training. So we wanted to just make it clear that this webinar is really an overview of screening, brief intervention, referral to treatment. It is not the standardized 4 to 12-hour Sbirt training for New York state providers to bill Medicaid. This workshop is eligible if you are a New York provider for KSAC, CPP, and CPS credentialing CEUs. And Christine, as it said on that introductory slide and in your registration announcements, will send an email and you can sort out the CEU needs. But we wanted to clarify that. That being said, Chris and I technically work for the Institute for Research, Education, and Training in Addictions. IRETA is our acronym. IRETA holds the Northeast ATTC grant, and as such, we're conducting these webinars sponsored by the Northeast ATTC. But IRETA has a significant history as an institution of experience with Sbirt. We were the training arm for the Pennsylvania state-funded Sbirt program in 2003 through 2008. We have been working very closely through HRSA funding as a subcontractor with the University of Pittsburgh School of Nursing, conducting Sbirt at the undergraduate level and in the professional level with already credentialed and licensed nursing staff. And we're starting an ER project with the School of Nursing. We are also working as a subcontractor with the State of New York doing Sbirt training. I just wanted to give you our background and experience base as an organization around Sbirt, as it's really been spreading throughout the country. There's lots of resources online, lots of great online curricula that following the webinar I could send you some links to look at examples. Normally when we train Sbirt, I show a lot of video examples. Unfortunately, with our technology streaming, we won't all be synchronous in looking at the video at the same time, so we're not going to show any on this webinar today, but we'll send you links so you can see Sbirt in action after we've analyzed and gone through all the components of Sbirt today. Okay, so I think I did everything. Chris, as always, if you need to interrupt me, you know that doesn't bother me at all, so we'll just pick up if anything's going on. And also, if people want to ask questions, you can go ahead and put those questions into the chat or the question box on your panel. Later, we will have a time where we can unmute you and ask for feedback, questions, or clarifications, or situations that you have already been using Sbirt in. Okay, so with that said, I'm going to go ahead and just start discussing Sbirt. So for this webinar, we're going to compare and contrast alcohol and other drug use as it relates to the continuum of use. And we will talk about, when we teach Sbirt, and I mentioned all those venues we've been teaching Sbirt over the years, I can't think of teaching without considering the continuum of use. Even though we'll learn that Sbirt is a public health approach, it's targeting people who are not dependent, it's targeting harmful and at-risk users. Of course, if you are screening and you're universally screening, you are going to uncover people who could be diagnosed with substance use disorders. So we can't ignore the continuum of use at all, and we'll talk about that in relation to Sbirt. We'll look at principles of screening, brief intervention, referral to treatment as a process, and we'll look at the stages of change and some MI strategies and their implications for the intervention process. I'll also show you some tools that people use for these strategies, these engagement strategies. But we won't be able to see those videos, but at your leisure you can watch them. They range in length from 2 to 5 minutes to 10. I don't think the longest video out there is like maybe 12 or 15 minutes that demonstrates a brief intervention, the whole Sbirt process. Okay, so let me keep going on. I don't see any questions. I'm just assuming we're going along okay. So if you haven't seen the acronym, this is just to clarify that Sbirt does stand for Screening, Brief Intervention, Referral to Treatment. And we're going to start off by, I really don't have a good sense of what the audience looks like, so I'm going to ask Chris to go ahead and launch the first poll question. And I want to get an idea of what you guys, sort of how you identify yourselves. So I was asking, which field do you represent? Mental health, addiction, physical health, education, or none of the above? The reason I picked those was because Sbirt really is an approach that could be used in a variety of settings. So there was always a chance that there was people coming from a diversity of fields. I can see we have 71% voted. Well, that's good. We'll give people a few more seconds. I don't believe there's a way to capture other, so I just put none of the above. Unfortunately, we can't tease out where people are from. But if you want to explain, those of you who selected none of the above, you can put in the chat box what field you do represent, and I can review that later. So again, we're at 84% here of, let's see, we have 33 attendees. People are selecting.
Probably one person noted that they're in the prevention field.
Oh, good. Okay.
Not listed.
Great. That's good to know. I wanted to really know because I wanted to tailor my comments to know, have an idea who was in the audience. So I think we're holding steady at 81%. Why don't we go ahead and share those results, Chris, so people can see who's in the audience. And as I said, if you did select none of the above, you can just write your field as someone did, and they rightfully so representing prevention, because we can see Sbirt in the school system. Definitely would be appropriately used there, and other areas. Okay, so I'm assuming you guys are looking at that 38% represent mental health, 27% addictions, 15% physical health, 4% education, 15% could not identify with any of the above. And as you share those, I will try to, Chris will read them, and we'll try to fit some of the approach of Sbirt into those settings or fields that you represent. The good news for me is that it is a bit odd for us because our primary audience as an ATTC to train are addictions professionals. That's our primary audience, but we do train a variety of people, and many people work in both settings, mental health and addiction. But Sbirt really was known for an intervention that is to be used not solely but effectively in a physical health setting. So I'm glad to see there are representation from physical health. I don't know if our listserv completely reaches all that, so I wanted to get an idea. It could be effectively used in a mental health setting if you're not actively screening for substance use disorders or harmful use around substances, and as I already mentioned, in an education setting. Okay, so I'm going to go on. And I'm actually going to ask a question to the group, so I'll give you a few minutes to process what's on the slide. I wanted to get an idea of what do you know about Sbirt already? You could just type in a few words or raise your hand with the yellow hand icon, and we'll unmute you, and or share what you want to know about Sbirt. Again, so I could try to see how some of the things I prepared relate more closely to your area of field and what you're interested in learning today. There's an awful lot about Sbirt out there. So as you're thinking about that, I'll just let you possibly type in the chat or questions box. What do you want to know about Sbirt? And what do you already know about Sbirt? Chris, do we have anyone? Let me look at the attendee list that's raising their hands. I would like to speak audio.
One person said that they just really don't know anything about Sbirt at this point.
Okay, good. So this is good. It's an overview. It'll give you a really good idea of the whole, what is Sbirt anyway? You've probably heard about it. You've seen articles. I think it was last week that Joined Together Online did a really nice overview of how nurses can adopt Sbirt. So if you're at all affiliated with any SAMHSA listservs or websites, you will know that SAMHSA has been promoting and funding Sbirt for years, but you may not know what are the nuts and bolts of it.
Okay, I have some more notes here that people are sending in.
Well, go ahead, read them, please.
Okay. One person wants to know how to integrate community partnerships working on substance abuse prevention.
Okay, community partnerships, all right.
Somebody else thinks it can be a very good tool for usage in short-term change.
Okay, true.
They want to know if physicians are able to be reimbursed for utilizing it.
I do have a reimbursement slide, so we will talk about that specifically.
Yeah. And someone else is interested in the screening techniques and in the referral process.
Okay, yes, we're going to talk a lot about screening and the techniques about integrating the results of the screen with based on motivational interviewing techniques, using the stages of change processing. I'm going to have stuff on referral, but there's a hidden vigor in referral because you have to make it meaningful for the person, so that means you have to make it local. So I'm going to talk about referral from our standpoint, but if you're going to do it, we'll have to do it from a local level. So you'll have to know who your providers are who actually do substance use treatment.
Okay, I have two more.
Okay.
Do you want them now, or do you want to?
I want them now.
Okay. I want to understand the limits and roles of professional and client's responsibility.
Okay.
And then we are going to use it for PCPs and OBGYNs to screen their patients for mental health and substance abuse issues.
That's great.
And
now, I do not have any of the mental health screens in this PowerPoint. I do know many states are in their pre-screening. They're folding in the depression, depression screen. So at the end, if I have a chance, I could grab one of them, or later we can email that to the group.
Yes. The last comment is, can you talk about the big initiative?
By big, I'm wondering if, so the person could further clarify with, and then I'll just move on to the content next. But in the meantime, if you want to clarify by big, you mean as a public health model, or do you mean as a SAMHSA, HRSA funded model? Because when we start talking about Sbirt these days, we cannot avoid talking a little bit about integrated care and healthcare reform. And so do you mean that big? Or so further clarify that. I definitely think I'm touching on that, but we could talk about that further.
Sure. Yeah, I'll give you the answer the next break.
Yeah. Okay. So I think we're going to close out this part of a discussion. And you can continue to type things as they come into your chat or question box. I guess I hid my question box, but when I get a chance, okay, I see. I'll read them too when I come back to that, maybe at the end, to make sure I've addressed everything. I just want to be able to track them myself. Okay, well, let's get into the meat of it. And really, I'm jumping right in, right? My next slide says chemical dependency. Well, I did say that we were going to talk about the continuum of use in relation to Sbirt for a frame of reference. So here's just some statistics for the National Epidemiologic Survey about alcohol and related conditions. So just to understand the scope of the problem and why really people are looking at this public health model from a primary prevention standpoint to offset people before they become addicted, and also cost savings, because if you can intervene early, you can avoid a lot of costs to our healthcare system, tragic costs to society in general. So for those of you in the field, this is not a surprise, but we do have people who are kind of more into physical health end of it. We saw that in the poll. We have people from education. So you guys may not be as familiar as mental health people or substance use addictions professionals are about the statistics, but 8.5% of adults in the U.S. met criteria for alcohol use disorder, and that's diagnostic criteria. That's a large percentage of United States adults that are working, that are semi-functional at some level. 2% of adults met the criteria for drug use disorder, and 1.1% of adults met the criteria for both. So we're talking about a super huge subset of our population that really, if they were properly screened and diagnosed, would meet these, would meet the criteria for these conditions. Well, we know this, but I just want to reinforce that substance use is associated with chronic health problems in general, causing death, accidents unintentionally, social disruption. It costs society a lot. So from a cost savings perspective, it makes sense for us to have a big initiative around offsetting people from these horrific, costs to society before they happen and intervening early. And so just from a productivity and the cost perspective, we're losing productivity time. We're adding additional burden to the healthcare system when we don't address addiction, when we allow the stigma around substances, illicit and the perfectly legal ones that we love in society, like alcohol, and the misuse around prescription drugs, to not be addressed. It results in a large loss to society. And then in relation to drug and alcohol as a factor, it's usually a factor in homicides, suicides, motor vehicle accidents, really costly consequences, even if the person isn't dependent and they're just using in a risky way. So I like Sbirt. I love teaching Sbirt. I teach it a lot with undergraduate nursing students who are, in their early 20s, because this is a win-win model. Just using this intervention could remind somebody that they should have more responsible use and have a good outcome. It could help somebody who may be, it could shine a light on somebody who might be having really problematic use and motivate them to change. So it is a win-win outcome, even if you don't see the results in your brief encounter with the patient. Okay, so I borrowed this slide from another ATTC, the Pacific Southwest ATTC, because I just liked how they conceptualized why Sbirt. Well, it's comprehensive. You'll see that in a few minutes. It's an integrated public health approach to the delivery of early intervention and treatment services. This is what it's meant to do. I don't know if this answers a person's question on how to integrate prevention, but there's a component of prevention in here already in this public health model. And it's for persons who have substance use disorders. You're going to screen them out and refer them for further assessment. You're not assessing for that, but screening. And for those who are at risk of developing those. It's meant to be in the primary care, mental health, addiction, meaning addiction as if you're not screening for mental health disorders, mental health if you're not screening for substance use disorders, and other community settings before severe consequences occur. That's the target audience for Sbirt, before the severe consequences occur. So that's the why of Sbirt. Let's talk a little bit more nuts and bolts about the why of Sbirt. I was on a few SAMHSA webinars. There's references to these on the slides. You can watch them. SAMHSA posts them a lot. And there, as I mentioned already, there's a lot online on Sbirt. But really look at these costs here. 12 million visits annually to emergency rooms by people who have mental health and substance use disorders. Rather than getting services in a continuing care, they're using this very expensive, costly emergency room for care. 44% of all cigarette consumption in the United States is by individuals with mental health and substance use disorder. Again, if we're not addressing it, the consequences of use further down are much more costly for the individual and society. And 70% of individuals who have significant mental health and substance use disorders have at least one chronic health condition. at least one. 45% have 2, and almost 30% have 3 or more. I don't normally read every word of a slide, but I think these numbers underscore why Sbirt and why we can't afford to not at least try to implement Sbirt in many venues across systems as possible. This slide, I was reviewing my PowerPoint last night. My husband was like, that's a bit of a busy slide. I know it is. So if you read PowerPoint Zen, it's not meeting a PowerPoint Zen requirements. I realize that. But it's a really great slide. I want to analyze it for a little bit. Again, this is from a SAMHSA webinar, and I borrowed it from there. You guys can view it. They're all up on YouTube. But it really underscores why we can't ignore all of these conditions and why we can't afford to silo our service systems and not address them concurrently. But this is out of the Washington State. I'm sorry, just Washington State data. Washington State is known to sort of really have a good data system. They look at their data. They use data to inform decision making. And so this study, it was from their Medicaid Management Information System, which is their Medicaid state system. And you know, it's primarily for their Medicaid population and people who are in their general assistance and unemployable programs. But this is very telling. If each state had access to this much information, I think we would be more than floored by the reality of what individual people are living with daily. So we see here in the blue area the chronic physical condition, the gray alcohol problems, and then the yellow mental health. Well, with the stripes, we see the crossover. That's 13% of people who have all three. So we know as good practitioners, whatever field you come from, if you're not subsequently addressing these comorbid chronic conditions and helping people, meeting them where they are to attain the highest quality of life by a brief conversation about something they can do to improve their quality of life, like reduce use or try to start to quit, then we're really doing a disservice to people every day. The other thing is, the reason I like this slide is because it does show, I mean, I know there's a lot of anxiety out there when I go to conferences and such. You hear, how is healthcare reform? What's it going to be like for specialty services? What's it going to be like for mental health services, et cetera? If you look at this data from Washington State, you will see that there are still people who just have alcohol and drug use disorders. And there's still people who just have mental health disorders who will need specialty care. There's the crossover of both, but there's this middle sector here that really are having, a triple trifecta, if you will, which makes it very hard to improve the quality of life if you're not addressing, at some point, wherever they are in their readiness to address it, their drug and alcohol problem, their mental health problem, and their chronic care condition. So to me, this is the why Sbirt. Why is it important? Oops, on the wrong way. All right, well, before I get into the continuum of use, let me scan the questions here and see if there's any. I see this isn't really a time, but I can always look and see what people are saying, because it kind of makes it a little bit collaborative for all of us. Somebody wrote, regarding the why of Sbirt, considering that the majority of adults diagnosed with alcohol abuse or alcohol-dependent diagnosis began drinking before the age of 21, how does or does not Sbirt uniquely address the adolescent population? Well, I was not going to do specifically talk about adolescents, but I can since you brought this up, because that is a very good point, because people establish these behaviors, these use patterns very early on in life, typically, especially in our society and especially around alcohol. And so just from a risky perspective, that's a dangerous time in life for youth, alcohol use. But Sbirt is quite effective with adolescents. There are screens. The CRAFT is an excellent screen for adolescents. And it's, the techniques are the same. You would just use a screen that's more appropriate to that adolescent population. Okay, so let's continue on with continuum. So for those of you who may already know this, it will just reinforce this, but for those of you that this is new information, when we talk about substance abuse, we're talking about the misuse of an illicit drug, prescription drug, or over-the-counter medication. And substance abuse usually has a harmful pattern, and it's used for mood-altering purposes. But the person who is just abusing is really not addicted or dependent. Otherwise, we would say they have substance use disorders. So Sbirt looks across that continuum, and the screens do give you the ability to say somebody's having risky use, hazardous, or harmful use versus dependency in relation to your intervention. And you want to target your intervention based on that screen, based on those assessments. Is it risky use or hazardous use, or is it dependency and this person needs referred on for further assessment? Or, consequently, are they using safely? Are they using low risk? Are they abstaining completely? And at that moment, you want to reinforce their use as a primary prevention, that they're making good choices around their use patterns. So when we talk about the screens that I'll show you later, we talk about what at-risk means. So I wanted to define that, and NIAAA defines at-risk for men more than 14 standard drinks per week, and for women more than 7 per week. So that's a guideline. That in and of itself alone is not well known by the general public. So even if people's intention is not to overuse, overdrink, they may inadvertently not be aware what safe or low risk drinking is. So I'm going to get into low risk drinking next. But if they're drinking more than this as a health education moment, that person is putting themselves at risk for harmful consequences. Or if you're repeatedly engaging in a pattern of abuse, like we just showed the definition a slide ago, that sets them up for potential addiction. So, that is an at-risk alcohol user. Low risk, I just mentioned what's the low risk limit. People, we have a long history with alcohol in our society, and people who want to use in a safe or low risk way, well, you would just encourage them to have no more than 2 standard drinks in a day and do not drink at least 2 days of the week. Again, with the Sbirt model, using these engagement strategies, just presenting this information to somebody could be a brief intervention. People may not understand that this is a low-risk use of alcohol. This is called the Drinker's Pyramid. It was put together by the World Health Organization, who did a lot and have a lot of research on Sbirt and a lot of the screens that we use in Sbirt. And it just shows you the use across society and who Sbirt is targeting. So that's why we like to always include the Drinker's Pyramid. So at the bottom of the period, we have 40% of adult population who are not using, they're abstaining from alcohol. In the middle level, we have 35 to 40% who are low-risk drinkers. Then going up to the top of the pyramid, we have 10 to 15% who are hazardous or at-risk drinkers. And I just defined both of those terms in the last 2 slides. So low risk, 2 or more, not having more than 2 drinks in a day and not drinking 2 days of the week. Hazardous users would be drinking, for men, more than 14 drinks in a week. And then at the top, we have people who are alcohol dependent or harmful users, making up 3 to 7%. When we teach this, face-to-face, we usually make this into a puzzle activity. We ask people, put the percentages next to the category. And I have to say 9 out of 10 people who attend the workshop to do that do not put 40% of the population abstaining. But you actually do have a segment of society who's not using alcohol for a variety of reasons. And if those people show up in your service system, you should reinforce that they're making good choices. You wouldn't just ignore it and be like, oh, they're not in our target area. We want to reinforce, this is the public health model, that we want to reinforce good choices around patterns of use. Speaking of patterns of use, many people do not know what a standard drink is. So a lot of what the Sbirt intervention is around is educating people that a standard drink is something measurable, just like you can understand how much sodium you intake and sugar and calories. If you're trying to use in a safe or low-risk manner, then you should know that one standard drink of beer is 12 ounces, not 14, or the yards of beer that are sometimes popular around football season and such. So this, again, an Sbirt intervention, making people aware of what a standard drink is so that they could safely use around their patterns of use if they choose to use. And then drinking episodes. We define this as a binge, and there is a screen for this, which we'll talk about. It's a pattern of drinking that brings the blood alcohol concentration to 0.08 or above. For a male, 5 or more drinks in 2 hours, and for females, 4 or more. Again, this is a primary, prevention moment to bring to somebody's awareness that, or an Sbirt technique, that that they may not know what the definition of a binge is, and here's something to guide their use patterns, to guide their use into low risk. Before we get to this question, I want to go back a few slides to the drinker's pyramid a little bit, because I'm going to revisit an inverted pyramid shortly after we talk about why we don't screen, even though we saw the scope of the problem in society. We know that there's a lot of harmful and hazardous users. Sbirt is targeting, let me see if I can do this and make this successful. Chris will tell me if it's going to be awful. I was trying to highlight. Sbirt's targeting here. This is the primary target of Sbirt. The hazardous and at-risk users, using educational methods to lower their consumption rate so that they can lower their risk. I mentioned the abstainers. We don't want to just ignore them and say, oh, they're already making good choices. We want to reinforce their choices around their patterns of use. And then for those at the top of the pyramid, we want to refer them for further assessment and possible treatment. So that is the Sbirt model, really in a nutshell. We're targeting the hazardous and harmful users, giving them strategies, advice, depending on your setting, in relation to their health condition, in relation to their social condition or their mental illness or their family situation, and then trying to elicit them to make some change around that use. Okay, so I wanted to ask the group what you guys think, and this is a point where I did want to either use the chat function or the raise your hand function to say, well, why don't you think we screen already? I haven't got to the screens yet, but I want to ask you guys, what do you think stops society from universally screening, and what's motivating us all to learn about Sbirt right now? And I'll give you a few minutes to process that, brainstorm. You could type it into the chat or the questions box. Or you can use the yellow hand icon and we can unmute you. What are some barriers that exist to screening for alcohol and drug use? Why don't we just universally screen? I'm working with I'm giving you guys time to think, and I see some answers coming in the question box, and I'll read those in a second. But I just mentioned we are working with New York State on Sbirt, and we are thinking about Sbirt for the project, but also it's a simultaneous thinking like Sbirt forever, because we would love to have really as many settings as possible do this brief intervention. It's a very validated evidence-based practice. It's meant to be brief. Of course, we're examining it today like under a microscope, so it seems like, oh my God, this intervention might last 15, 20 minutes. It's not meant to last that. It's meant to give people feedback on their screen, assess quickly their readiness for information or willingness to change their use patterns, and move on to whatever brought them to your agency or your PCP office. Okay, so here's what I'm reading online. Okay, let me get to the answers here. I guess I'll go backwards. Question makes patients and providers uncomfortable. There are different views of how much alcohol use is normal. Very, very, very true. That's why just having some educational information around or using a health visit as an opportunity to let people know what low-risk use is or what a standard drink size is, can sort of diminish that. But that's so true. We see a lot of self-examination about our use patterns when we talk about Sbirt. People present other issues or concerns not connected with alcohol. That's true too, depending on your setting. We would think, what we try to do, we try to tell people when we're teaching to a specific setting is you have to make that connection for the person so that it makes logical sense in your mind. Why are they bringing up my drinking? And then if they don't show a willingness to take in that information, you move on. You roll with the resistance and you move on to the presenting condition. Some person wrote, the time involved and the lack of resources available for referral. That's true. We know a lot about our world of treatment, but mental health facilities may not know, PCP, OBGYN offices may not know. So that's very true. All the paperwork required for payment currently is out of control, and it requires one more requirement. That's true too. But if you can systematize it, if we say Sbirt forever, and we do, I know of a couple clinics here in Pennsylvania who were Sbirt funded, who still do Sbirt to this day, and they stopped the funding in 2008. The reason they were able to sustain it after the grant money went away is because they systematized it. And the cost of putting in that effort came down, and they reimburse on the codes I'm going to show later. They're walk-in clinics, so they see people sometimes once a year, sometimes not for many years, sometimes many times in a year. And they have a system to annually do an alcohol and drug, audit and DAF pre-screen or full screens on everybody, and then they reimburse for those. And they do a brief intervention on the results of the screen. So if you're really serious about Sbirt, it's true there's some work at the out front, but if you systematize it and make it Sbirt forever, there's a lot of rewards, and there are reimbursements. Okay, questioning makes patients, providers uncomfortable. Okay, I read that one. Let's see, there's one reason is a lack of referrals, and it's easier to avoid the problem. And alcohol is so integrated into social norms of society that within the profession, oops, I'm sorry, the question jumped away from me. I think as more come in, I get lost. Here, let me go back to that question. I don't know where that one went. Lack of referrals, easier to avoid the social norms of society that many within the profession and those that influence societal norms prefer to normalize alcohol use. Very true. I know there's some prevention efforts, and others on this call might know that some college campuses are making an initiative to show that there's a lot of non-users. They're just silent, So instead of that fraternity party or sorority party or just party, others could say, hey, we're getting together to watch a movie, and that they have to be more vocal on campus because there are non-users or low-risk users. They just don't come to the forefront. Not enough time, as many issues need to be screened. That's true. How many more screens? I was at a conference last week with primary care doc who's like, okay, I'm supposed to be screening for depression. I'm supposed to be screening for drug and alcohol. I'm supposed to be screening for domestic abuse. A lot of, then it starts getting less brief. My answer to that is, again, we have to look at where we're trying to implement Sbirt. Maybe it is too much for the doc to do. Maybe that's something that needs information that needs to be collected in a different area of our health setting through a pre-screen. And if somebody needs to do the full screen, then they would do the full screen. And then the doc would maybe just follow up with the results of the screen. Not enough time, as many issues to be screened, maybe literacy or language barriers, perceived stigma and reluctance by professionals to confront. Patients may not want to be asked these questions when at the family doctor. That's true. There are some studies out there that say that actually parents are motivated and willing to answer questions at the pediatrician's office about their own drug use because they're connecting that with being a good parent. Medical doctors not comfortable asking these questions may feel it is not their job or they're just not getting paid for it. Very true. Labeling, time, minimizing. So very good. All great answers. I wanted to hear what you guys think, because you guys are all professional adults who always have better ideas than I do. Well, if you have more ideas, please, you can continue to always add that in the question box. But I'm going to go on in the PowerPoint with some of the things why we don't screen intervention, ideas that we've come across over the years. And this is things you guys have already touched on. Lack of awareness and knowledge about tools for screening. That's true. Many people don't use it unless it's a requirement, and so they're not even aware what are the tools that exist. How easy are they to use? Discomfort with initiating the discussion. You guys mentioned that. Sense of not having enough time. Some of the effectiveness studies I'm going to show you are really based on a 5 to 12-minute brief intervention. No more than 12 minutes, and most of them aggregate around 5 minutes. Because the goal of this intervention is to give the people their feedback of their use and then move on. If they're not ready to hear it, not willing, or if they're ready and engaged, you want to probe more. But if it's not enough time, you want to give them that information and then move on to whatever the presenting issue is that brought them to your agency. Healthcare, there's negative attitudes towards substance abusers because there's a lot of stigma involved in that, a long history of that. Pessimism about the efficacy of treatment. A lot of people don't understand multiple treatment episodes because we've been treating addiction in an acute model for many, many years. Alienating patients around, we might use in a risky way, so how am I going to say something to this person who just came in here for their EAP visit around their use when my use might be excessive? So you might worry about alienating your patient and have worried influence around your own use patterns. Lack of guidelines for brief intervention. That's true, and I have some slides on that because we do get the question, what is the difference between brief treatment, brief intervention, brief advice? I'm going to try to articulate that. Again, some more barriers, and you already said this, referral, uncertainty about where do I refer people. If I ask, God forbid, I find out they're willing to change, they're ready, they're motivated, and we're not sure where to send them. And also, sometimes when we send them, there's waiting lists. No insurance or limited insurance coverage for screening. That is changing, though. I think we started Sbirt in 2003. It's definitely changing. In fact, about maybe a month ago, a commercial insurer asked us to make sure we were listed on we have an Sbirt overview PowerPoint on our website, and they asked to be made sure that they were listed. And I think that is wonderful because they want people to know they're reimbursing for screening and brief intervention. We were excited to hear that. And then, there's some legislation that on parity that should help with that, and also healthcare reform. Whatever shape it takes. I don't want to get into political discussion about that, but we do know we have to look at our healthcare system. We do know there are changes already down the road. There are changes being examined, but we're not going to completely go backwards. So hopefully those changes will improve access to treatment. There's a lack of education and training about the nature of addiction, that it is treatable, that people can change their use patterns, just simply reduce use and improve their quality of life. But let's talk about some opportunities too. I do like to see, because you can get overwhelmed by the barriers, and it can be like, okay, great, I know all the barriers, I'm just going to go back and do what I normally do every day. But let's look at our opportunities. When alcohol and drug screening becomes more routine, patients actually have greater satisfaction in their services, in a healthcare setting, a mental health setting. We know they can be more compliant with their treatment modalities if they're not using substances in a risky way. And there could be better management and follow-up as a result of that. And also families have expressed, there's a ton of SAMHSA-funded studies out there, data's coming in from that. I'm going to share a couple results now that people do report an increase in their quality of life, even around reducing use, or even those who are using in a very risky way, reducing the risk around their use, for instance, not using IV drugs or using clean needles. So, there is something to be gained from just highlighting this and asking a person, how can you use some more safely? How can you reduce your use so you can, have a higher quality of life and not necessarily abstain? This does cut across the continuum. It is a primary prevention public health model. And another one, I don't really usually get into clip art and get all excited about it, but I like this clip art piece because really Sbirt is planting a seed, and we do not know where in the process somebody is. You don't know. Maybe you were the person to motivate them to actually make a huge difference in their life. But if we don't ask, if we don't screen, we don't give information, we totally know the outcome of that nothing will change. So just showing concern, especially in a healthcare setting where patients already have this expectation that in healthcare you're going to ask something uncomfortable about sex or drugs, to go ahead and ask. We tell the nursing students that all the time. People do expect you to ask them uncomfortable questions. And if you can get past the idea that they're going to answer me, truthfully or not, you're not judging their answer. You're just giving them information where they are, that you could be planting the seed for significant change. Or you could just be the first person on the road that's ever mentioned it, and you're just planting the seed to begin with. But if we don't do anything, we'll never know. And then going back to what I mentioned earlier about costs, we know, and this is sort of like an economic frame of reference here, that if we are reducing use, then we'll have less people on the roads driving drunk or intoxicated, and that will save lives and reduce costs to society. And if we, going back to the drinkers pyramid for a second in our minds, let me just go, oops, yes, start my annotation. I just want to go back to the slide really quick to make this point that this level, these two percentages of people in society, has a greater economic impact. I'm sorry, I meant to cut it right there. We have a greater economic impact if we are having people use in a safe way, meaning they don't drink and drive, they don't use IV needles, or they reduce their use because they're going to have less consequences overall. So overall, our impact from society, the financial costs of society go down if we can intervene earlier. So that's our last opportunity. Reduce hospitalization, and the value in terms of prevention are enormous. Okay, I sum this up as Sbirt in 5 points. Now, as I mentioned, I didn't change the slide on purpose. The role of the healthcare professional. I realize we have mental health professionals and drug and alcohol professionals, education professionals on this call, and others. So you can insert your profession here because it's relevant to everybody. And this is Sbirt in a nutshell. What can we do to help? You can identify use, misuse, and problematic use with a simple screen. Some of the screens are down to 2 questions. There's a 1-question binge drinking screen. That is what we consider a pre-screen. If people say no to that, you wouldn't do the full screen. You can make a connection of their use or misuse to a health-related condition, or say if they're in a mental health facility to their presenting mental health issue, or if they're in an education facility to something in their their social life. You can make a connection for people around their use with their presenting condition. We can simply have consumption reduction and have a large positive outcome on people's lives. You can engage in a brief intervention, and then you can refer for formal assessment for those who show that they do need formal further assessment and referral to treatment. So this is the 5 steps of Sbirt, really in a nutshell. How do we approach this process, though? I think that was one of the questions. Oops, I lost my panel for a second here, but I want to go ahead and check in before I start really going into screening 100% and see if there's any burning questions. Chris, do you think there's anything major here?
Holly, no, we haven't had any new questions. I just have one comment that somebody made a little while ago.
Go ahead.
And it's, so as a side note, the alcohol industry makes a majority of their income from high-risk drinkers, especially those that are alcohol dependent or underage?
Yeah, let me read that again. I'll process that in a minute. I'm not sure. I mean, I think that's a conclusion that you could probably draw. I don't have information in specific about the alcohol industry, but I don't have a background in economics. Chris, can you shoot that to me in chat so I can read it and maybe process it in a second? But,
yeah, I'll send it right over to you.
Yeah, I do think, I mean, it's not, I think you can make that logical jump, that the large percentage of that industry is coming from that section of the pyramid. Binge drinking, it's a huge problem, and it's very, very risky, and there are a lot of unintended consequences around that, and it's unfortunate that we can't shine the light on people to make a safer choice around alcohol. So, I mean, this is one effort to do that, basically. In my opinion, this is definitely one effort to get to that. And that's why I always think this is like a win-win intervention, because this is sort of can counter that. We can improve people's awareness over the risk that they're really assuming when they use, unintentionally in a very harmful way, or intentionally because they want to blow off some steam. And that's what most people say. I just want to blow off some steam. I need to blow off some steam. That's true. Well, let's examine our use patterns around that so we can do that in a safer way for yourself and others around you. Okay, so identification of use, misuse, and problematic use. How can we approach this? Well, these are the screens. And I just want to mention, I'm going to do a time check here. Oh, we're almost an hour in. The goals of screening is to identify hazardous and harmful drinkers or drug users. We say drug users too because, illicit drug use we assume is harmful because it's illicit drugs. People don't know what they're actually ingesting. And then misuse around prescription drugs, which is a huge problem. Many of you probably read that prescription drug overdoses, accidental overdoses due to prescription drug use is higher than, fatalities are higher in that sector than car accidents now. We've outpaced that. Also, another goal of screening is that, we'll see those who could be dependent, and we would show them to further assessment, or refer them to further assessment. Use little patient and staff time, not just the staff time, but patient time, because what? They're presenting in a non-addiction setting. They're coming in a mental health clinic or an OBGYN or PCP office, so they're not really having the complete expectation that they're going to talk about drug and alcohol use. So we want to in with the intervention, give them the results of the screen, assess their readiness, and move to their presenting condition. Create a professional, helpful atmosphere, and then provide them information needed so that they can make a choice around their appropriate intervention. I think somebody wrote early on that they wanted to know about people's roles and responsibilities in the Sbirt process. This is grounded in the philosophy of motivational interviewing, that the responsibility for change is on the patient. That we can give them the information, but it's really their decision and responsibility to make a change when they're ready. That immediately puts the nursing students at ease, because they look at me like I'm this crazy lady who walks into their school of nursing class. They're literally studying, taking blood gases and, very medical terms. Here we're talking about doing a drug and alcohol screen. They even understand that. But they don't buy that giving people information in and of itself is an important intervention. And so we do our best to convince them of that. And I think we've been pretty successful with the students, because making that connection with their health condition really is powerful. Okay, so well, that's just really a transition slide. Let's talk about why do we know Sbirt's effective? There's a ton of literature out there. One of my colleagues, Jim Ayala, loves this slide as a convincing slide. So I think it does merit some discussion. That the American Journal of Preventive Medicine said that alcohol screening and counseling is one of the highest ranking preventative services among 25 effective services evaluating using standardized methods. By effective services, they were looking at like screening for blood pressure, screening for mammograms, like regular screens that now we accept as routine. We should be doing that. but we're not doing it. So since these current levels of delivery are lowest compared to other services, they deserve special attention by clinicians and our care delivery system, because ultimately we can have the biggest bang for our buck because we're not delivering these interventions and these screens at all in a primary care. I mean, we've seen some emphasis obviously through federal funding in order, they've been funding projects at the state level, they've been funding medical education settings in Sbirt. So we're seeing some movement from this, but we're certainly not seeing universal Sbirt screening. And so if we saw universal screening, this would be, you know, a highly ranked and cost-effective preventative method. So we should be doing it. This is a study that I was referring to that SAMHSA has done about looking at their funded sites since 2003 or prior to 2003. And this data set is over 100,000 individuals responding to their GPRA, or Government Performance Results Act survey. And here are some of the results. Of the 100, I think it's 104,000 people who, those are 104,000, 400,000 people were screened. 104,000 were screened positive. Of those 104,000, roughly, rates of illicit drug use dropped by 67%, 6 months after patients using illicit drugs had received help through an Sbirt program. That's a huge amount of change. And it was sustained. Of course, it was self-reported. I'm not a statistician. We could examine the data. But I would assume that this has had an effect on people. At those level of numbers, that this is a true effect. Heavy alcohol use dropped by 38%. Now, just looking at illicit drug users who received brief treatment or referral to specialty treatment, they also reported some quality of life improvements. 29% generally felt healthier. 31% reported fewer emotional problems. 15% reported improved employment status. 64% fewer arrests, and 45% who were homeless reported no longer being homeless. And this is just of the illicit drug users who received brief treatment, referral to specialty treatment. It's just to point out, people can change. If we give them an opportunity, if we're targeting our technique, that they can make quality of life improvements from a very simple technique. And here's some information on Sbirt saving money, because again, this is a cost. You know, we're talking about the economic cost of society. Here are some of the cost savings. This was a performance evaluation study, not a research project, but they experienced a $4 for every $4 invested. They saved $4 for every $1 invested in their Sbirt approach. They saw a reduced cost in alcohol use, emergency department visits, which we know are costly, hospital days, legal events, and motor vehicle accidents. And then you can see Texas, who's had an Sbirt project for a while. In fact, using Texas as an example in another slide, reported a $40 million a year savings because due to emergency room usage droppage and the shift from inpatient to outpatient treatment. So here's the inverted pyramid that I was mentioning about Sbirt as a response option. We love this slide and borrowed it from another Sbirt training. That when you're talking about abstinence, people who abstain here, and then the infrequent users here, that's a primary prevention. So Sbirt is primary prevention. You conduct it on them, and you're just reaffirming their use or patterns are safe, or they could consider even safer use patterns. For people who are dependent here in this range, then we want to refer them for alcohol and drug assessment and possible treatment. We want to get them where they need the help that they need and where they are, best, seen in the system. And then for those who have problematic use, a brief intervention is a legitimate target for those who are having risky, problematic use. And that can be conducted in any of the settings that were mentioned on this webinar and were mentioned in the registration materials for the webinar. I mean, I guess what we're saying is, if I go to the doctor and I'm like drinking probably maybe 1 or 2 glasses of wine, I shouldn't be drinking a week because I need to unwind or I feel stressed, and my doctor's seeing me for anything else, it's okay the next time I come in if for them to say, were you able to cut back a little bit? But that's the kind of reinforcement and health connections we want to make, and that in itself is a brief intervention around problematic use. Okay, so let's look at the screening instrument. I just want to reinforce that we're actually using validated alcohol and drug abuse screening tools. Many people, one of the reasons that it's underutilized is because people outside of the field don't realize that there are simple screening methods that can be embedded in their office visits and looked at and incorporated as a protocol, and they're quite simple. And then, when you get immersed in this, sometimes it's easy to fall into assessment versus screening. But we want to highlight there is a difference here. We are not assessing people. We're screening them to say whether there's a possibility that a condition exists. We're not assessing them. You would have to refer people to further assessment to confirm the existence of a condition and its severity, and that has to be done by specialty treatment and diagnostic instruments. When we look at screening, we're also looking at other factors. Maybe their patterns of use. Maybe they present and they're a low-risk user, but they have high negative consequences of that use. We could make that connection in the Sbirt model. Yes, you're using, low risk. However, you're having legal consequences due to a divorce pending in a child care, custody situation. Maybe they're presenting with this issue at an EAP setting. And you might just want to connect their pattern of use with a negative consequence. What if your ex finds out, etc. The context of the use. Well, maybe you're only drinking on weekends, but then you're finding yourself having unprotected sex. Again, looking at their patterns of use and their risk level and the context of their use. Any previous treatment. If you are aware of that as you're a healthcare professional, a mental health professional, or in that setting, to look at previous treatment episodes in relation to their patterns of use. And then their control and use and their motivation for use. So the screens. I'm going to go on with all the screens, and then I can see some comments and questions coming in. I'll stop right after I get through the screens before we get into the brief intervention. So the screens that are generally used are the CAGE, the audit, the 3-question version, or the full audit, which is 10 questions. There's a 3-question drug screen that has been effectively used in the many Sbirt projects, and also the one question binge drinking question. I guess that's a little redundant to say that. But let's look at the CAGE. And for those of you who aren't familiar, the CAGE really consists of these 4 questions. Have you ever felt you had to cut down on your drinking? Have people been annoyed? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had an eye-opener first thing in the morning? So the CAGE has been used that if anybody answers yes to these questions, any of these 4 questions, you would do the full audit. And you might ask why. That's one way of doing it. To my knowledge, the CAGE is quite easy to remember. There's also the CAGE aid, which instead of just saying drinking, it would say drinking or drug use, drinking or drug use. Validated assessment, easy for people to remember. The thing about the CAGE is it just, teases that. It doesn't really give you a zone of use, risky, hazardous. And so that's one of the maybe downsides of it. But let me tell you, people remember the CAGE. They remember the questions on the CAGE. And if you're looking for simplicity, this is a nice screen. And again, if anybody would say yes to any of these 4 questions, you could do the full audit, which we'll talk about the audit in a second here, and that would tell us their severity of use. Okay, so the audit is a 10-question instrument. It's a highly reliable and valid instrument. It's been validated in multiple languages and cultural settings. And then there's a 3-question version, and it does screen out. It will give you a score that screens for hazardous drinking, harmful use, and alcohol dependency. So that's why most people are tending to use the audit now. There's other assessments out there, but the audit is starting to tease out as the easiest. Because again, you can use just the 3 questions. You can, if they say, not 0 to all first 3 questions, then you don't have to go further. But if they would answer anything more than 0 to any of those questions, they would go on to the full 10-question instrument. So here's the first 3 questions. How often do you drink anything containing alcohol? How many drinks do you have on a typical day? How often do you have 4 or more drinks on one occasion? Now, often people are answering this. It could be done in interview style, or it could be done in a, as part of a pen and paper. And you just get the score of it, and that would indicate what to do next. There's also tablet PC technology. People are incorporating it into that. And so that the score would be generated, and then you would know what to do. Do you do the full audit? And then once they would do the full audit, if that was the case, what the score was and what the brief intervention should be tailored to. Okay, about drug abuse screening, the DAF is risen to the top. It's a 10-question, screen for potential involvement in the use of drugs. And there's a 3-question pre-screen for drug use that has been effectively used too. Because again, we're talking about using little patient and staff time, but use it in an effective way. So the pre-screen is a lot of the times the way sites go. And only if they score on the pre-screen would you do the full screen. So here's the 3 questions. These are not, 2 of them are from the DAF. They've been modified, but they're quite effective in a setting. If you're not doing a research study, you could quite easily use these questions as a way to indicate, should I do the full DAF, which is highly validated. So in the last year, have you used drugs other than those required for medical reasons? In the last year, have you used prescription or other drugs more than you meant to? And which drug do you use most frequently? Again, can be asked interview style, can be asked as part of intake forms, can be asked, in some sort of electronic mannerism, if you have that capability. I guess the important thing to say about either the audit or the DAS is we have been in settings in which they were actually collecting this information, but they don't do anything with the score. They just collect the information, and they get a score if somebody's drinking too much in a hazardous or harmful way, but nobody does anything with the score because they are in an ER setting, for example. So it's not really helpful if we just collect this information. We don't give the feedback to the patient. You scored an 8 on the audit. That indicates some risky use. Would you mind talking about your use around alcohol with me? And then there's the 1-question screen for binge drinking. I like this question because it's not just a screen, but it is a way information for the patient just by answering this question. When was the last time you had more than, for a man, 5 drinks in one day? I mean, that in and of itself is a good indication of, harmful or risky use because it's considered a binge. Did you know that more than 5 drinks for a man on one occasion is considered a binge? There you go. There's a brief intervention. There's some health education. Make a connection with their presenting condition, and you've done a whole Sbirt. And then for women, you would insert 4 drinks in one day. Okay, I'm going to stop here and look at what's going on with the question board before I go on. I guess I can keep my slide up.
Chats, you're all caught up.
Okay. Oh, I am?
Yes.
Oh, good. Anybody has any thoughts? Okay. Let me look at the time, too. All right, we're doing good. So hopefully I shed some light on the screens. I mean, I didn't go into the scoring of the screens. The citations on the bottom of the slides can tell you they're very easy to score. You total the score. There's zones that indicate harmful use, or for further assessment. And I was just at a training last week, and somebody was saying, I like to start, we were practicing role plays on how to introduce the screen, how to introduce the results of the screen, etc. And somebody really summarized it best as saying, I like to just say, here's the results of the screen. Give them maybe a health education, like I gave the example with the binge drinking question, health education. Did you know that this is the healthy guidelines for drinking? For a man, no more than 5 drinks in one day, or more than 5 drinks in one day is considered a binge. And then you ask them, what do you think about that? How do you feel about that? That could be a segue into a brief intervention right there and then. So brief intervention. Let's talk about some definitions here. And Christine will send you the slides following this webinar, so you'll have these. But Chris, I'll have to send you the new version. I did add 2 more slides because when we've been doing Sbirt for these projects, sometimes in the States, there is some discussion about what is brief treatment. Is brief treatment something that should be licensed and certified or not? So there's some definitions here, but we're just talking broadly about brief interventions. They are aimed at identifying real or potential alcohol or drug problems and to motivate individuals to do something about it. And that something might be just take the information that day and moment. It might be reducing their use or finding a safer way of using. That is a brief intervention. I'm not interested in the material today. Thank you very much, Holly. Okay, I understand that. I've engaged them in my brief intervention, and we move on to the presenting condition. Let's look at a little more definitions. Brief advice. And these definitions are out of the University of Texas Addiction Research Institute. I mentioned Texas was an early funded Sbirt project like Pennsylvania and other states. And they just had this definition and they articulated it nicely, so we incorporated this for our general Sbirt discussions. Brief advice is a one-time intervention for short consultation and literature. So for instance, if I'm drinking 14 drinks every Friday night, I come into my PCP office or my OBGYN office, or maybe I'm in my, in my EAP office. They give me the information that for women that is considered risky, at-risk drinking behaviors. And then they go on to the presenting conditions. They might hand me a card that shows a standard drink or what is risky drinking use or something about alcohol use, and then they move on to whatever brought me to the clinic, agency, etc. Brief intervention, 1 to 5 short motivational sessions to encourage and promote healthy behaviors. That's sort of like the example I was saying earlier when I said, well, maybe I'm drinking too much. I go to my PCP and they ask me 1 month and I indicate, oh, I'm drinking a little too much. And then the next month I come back for some other follow-up and they engage me again a second time in my drinking. Oh, were you able to cut back? Were you interested in cutting back? Again, a nice short intervention, and it's encouraging, connecting to the healthy behavior that brought me to that office, or relating to an unhealthy behavior that it might contribute to. And then brief treatment, 1 to 12 sessions of substance use intervention based on some evidence-based practice like MET or CBT, motivation enhancement therapy or cognitive behavioral therapy, provided by specially trained substance abuse counselors. Here in Pennsylvania, we got into that too, because if we start saying brief treatment and you see people over and over, does that get into treatment? So here in Pennsylvania, they were calling it intensive intervention. I was at a conference 2 weeks ago in which a person from, very much involved in healthcare reform, in the medical home, integrated care, was talking about, we don't know that much about this brief treatment. What are the outcomes? That might be a good research question for a budding program evaluator or researcher to look at. Maybe these 1 to 12 short sessions can have an effect. I mean, we saw some of the SAMHSA data about it, but we don't have a lot of hardcore research on the effectiveness of these short engagements around changing people's use of substances. So, we have to do more research on that for sure to look at outcomes. But I think some of the data coming in is very promising. I shared that with you, that people 6 months later were able to change behaviors around illicit drug use, and show that they felt they experienced an improvement in their quality of life. So it's worthy of us to continue examining these short motivational exchanges, especially outside of an addiction setting, where the motivation can be different than in an addiction setting. Many people who are straight-up addiction counselors have a very hard time actually doing Sbirt, because our tendency might be to treat everyone as if they're at the top of that pyramid, when actually people who aren't ingrained in their addiction, are not suffering from substance use disorder, actually can have an easier time of taking in information and making small steps to change their consumption use, because they are not in active addiction. So sometimes we have to change our frame of reference, and I'm referring to the, let's see here, 27% of people who identified as an addictions professional on this webinar, that this is a bit of a different type of thinking for us. We're thinking of people at the top of that pyramid, where we're really trying to target people in the middle who have a little bit of an easier time adjusting their behaviors around their substance use. So this brief intervention and brief treatment can have effect on them. Another definition, and this is going more towards how brief intervention is grounded in the theory of the stages of change and motivational interviewing techniques. And I always have to say that, because this is not, I'm not trying to say this is a motivational interviewing training in any way. That is a skilled, skilled practice that should be done over time with a person who is a trainer that is coaching you around motivational interviewing skills. But there are techniques of motivational interviewing that are embedded in Sbirt, such as engaging the patient in a short dialogue, giving them feedback. Here's the results of your screen. What do you think about that? Engaging them, simple advice, listening to them identify a goal or help negotiate a goal with them, and then following up again. How is assessing those stages or readiness to change influenced on with the Sbirt? Well, I mean, this is an overview training. We're not, again, going to go into examples of how we do this, but we do try to train people to listen, do reflective listening of the patient to try to assess where they are willing to change and match your intervention to that. Are they just not even aware that they have any issues around substances, and they're not even in pre-contemplation? Or maybe they are just on the verge of pre-contemplation. Maybe they're all the way in the step of action, and if you do really good, careful listening, you can see examples of how they've taken action steps to quit smoking. Well, I try to stop smoking in the morning. I don't have my first cigarette until lunch. Or I try to stop smoking at lunch. Those are action steps. So to listen reflectively to patients and match your intervention to where you think they are. This slide here is really just talking about how this previous slide, if you listen for somebody's readiness and you match where they are, and you use that as their motivation to change, has some effect. Now this study is a bit smaller, 1,260. That's not bad. I wish I had that many in my dissertation. That's a pretty decent sample size, but it's smaller than the SAMHSA one I mentioned to you. But this is what some results of that study showed in consumption reduction. And again, Sbirt, a good outcome of Sbirt is people just say, hey, I'm going to use less. I'm going to use in a safer way. This is consumption reduction. With 5 minutes of advice, a discussion, here's the results of your screen, here's healthy guidelines, 21% of people were able to change as compared to controls. 27% of this 1,260 with 15 minutes compared to 7% of the controls. So I think that there's some evidence that this has an effect on people, and that they can, in that middle area of the pyramid, make these changes in their life and have good quality of life outcomes for themselves. Okay, getting back to some of the brief intervention techniques. So, I mean, this is the FRAMES model. It is embedded in principles of motivational interviewing, but I'm not going to elicit that. I'm just going to use it I'm not going to describe them. I'm just going to talk about it as we're looking for these things in our engagement with the patients. We give them feedback. That the responsibility for change is on them. You're just being neutral provider of services, whatever service you provide, mental health, health care, that you are in a position to give them some information or advice about healthy guidelines for drinking or safer ways of using, ways to cut back, offering them a menu to select from, but they choose. It's their responsibility to make a choice or change. Expressing empathy for their situation and eliciting self-efficacy. I just want to say real briefly that this project I mentioned over and over at the School of Nursing, that we work with undergraduate students and teaching them this technique. We see them in their junior year. We do this intensive training. They actually get to practice Sbirt in their live clinical rotations in psychiatry, in their psychiatric rotation, in their OBGYN rotation, and in their med-surg rotation through, with faculty supervision. Then we see them a year later in their senior year. We do a booster session, and we ask them their opinions about, do you feel this is an appropriate role for nurses? Do you feel confident to do this? And sometimes in these little training sessions, I get some feedback from students over the years, because we have been doing this since 2006. They're like, depending on their clinical rotation, they're like, well, we really don't know what to do, because we believe we should do Sbirt, but guess what? We don't know where we're going to be working. We don't know if the unit we're going to work on is going to embrace this. So what can we do? Because, these are students going into a helping profession. They actually do care of their patients. The single thing that we tell them that they could do that could improve somebody's, outcomes, that's quick and easy, that even if they don't know if the unit they're going to work on is going to formally do an audit or a DAST, is they can improve somebody's self-efficacy to make a change. They could just, and I'm not even just saying give a positive affirmation, because I got that feedback last week when I gave this big spiel like I am to you all right now about self-efficacy. But it is very true that we could improve somebody's self-confidence to make the change. I always tell the students, you guys have high self-efficacy. You're like, hey, I can do this. I can become a licensed bachelor's level nurse. But oftentimes your patients, especially those who have, think of that Venn diagram from Washington. Think of all these patients. They have diabetes. They're drinking too much. They're probably having a lot of psychosocial stressors. They might even have mental illness that they're dealing with. If we can improve their self-efficacy to make a small change, even if that's not smoking one time in a 12-hour period, then that is a good outcome of a brief intervention. So it is a win-win. Their self-confidence, if they can make some sort of change, whatever that change is, you can take that with you no matter what unit you work on. Okay, let me move on. The spirit of motivational interviewing in relation to brief intervention is collaboration. We want to draw out what is important to that patient. That's why we want to make the connection for the presenting problem with the results of their screen. We don't want to just come out of the blue with this and say, oh, wow, you're a high-risk drinker. No, we want to make that connection with their EAP visit, with what is important to them by drawing that out. And then we want to rely on their autonomy or increase their autonomy through increasing their self-efficacy. We want to express empathy, and I've said this over and over and over. We want to roll with resistance. I didn't say roll with resistance, but I said many times, if they're not ready to change, we want to move on. That's roll with resistance. We want to move on to their presenting condition, because this intervention is not an intervention for drug and alcohol use. It is a brief exchange of information about their screen, their use patterns, and whatever condition they brought in. So if they're not ready and willing to talk about it, just roll with resistance and go right on to whatever they brought, what brought them into your agency or clinic. Another thing that reminds me that we tell the students when we're practicing is to tell the patients, show some respect for them. A real simple technique. I mean, the students are literally, like all students, like, show me how to do it. And we're like, okay, here's one thing you could do. You could always start a conversation like giving them a choice. Do you mind me talking to you about the results of your alcohol screen? That's showing respect for the patient. It opens a huge door. If they say no, you say, I understand, and you move on. Okay, so you're here today because you are following up on a broken arm. You roll with that resistance, but you show respect for them. I think, you guys, we've talked about this whole supporting efficacy thing, autonomy. Also developing discrepancy. I think that's another thing that we emphasize a lot when we're practicing as Sbirt with people who are actually going to be doing this and in their setting. So right, you guys are a broad audience, but often when we're doing Sbirt training, we know specifically the settings that people are trying to do Sbirt. And we talk about ways that we can elicit discrepancy in a person so they can make these small changes themselves. This is my favorite thing because there's a lot of good outcomes from a brief intervention. Even if somebody reduces their use, even if for a short time, that's a good outcome. If they stop using, that's a good outcome too. If they're thinking about changing, that's a good outcome. And if they do need further assessment and they agree to accept it, good outcome. So this is the win-win part of Sbirt. Again, I go back to that clip art. I'm not going to physically actually go back to that slide, but the image of that slide, I said I love the seed planting and the little sunflower in its stages because we don't know where you're planting that seed. It might be that you're just the final fertilization of change for that person, and just by bringing it up in that setting, you can make a difference. But if we don't, we absolutely know for sure we're going to have a bad outcome. The next couple slides are really just slides that are some of the tools that are commonly used in Sbirt. When you see the links to some of the websites, and you can watch an Sbirt interview, an Sbirt brief intervention, you'll see sometimes the readiness ruler. And this is an example of how you can elicit somebody if they're ready to make a change. And it's also something tactile, gives somebody the opportunity to look at something visual and maybe even circle it on a sheet of paper and say, on a scale from 0 to 10, where 0 is not at all ready and 10 is very ready, how ready are you for reducing your marijuana use right now? And it does open a window of opportunity of conversation with the patient. And it gives you a good assessment of where their stage of change is. The other one we use is the confidence ruler. How confident are you on a scale of 0 to 10 that you can meet this goal of cutting back your marijuana use from 7 days to 3 days? So there's a ton of tools out there on the website, links that we'll share. There's very many variations on the readiness ruler, the confidence ruler, some of the healthy drinking guidelines, the drinker's pyramid that you could just adapt in your setting or make something that's new and relevant to your particular setting. Okay, we're doing good. Yeah, we're doing good. I'm going to get to the codes here quickly. I'll check in on questions right before we go to referral to treatment. But here's another example. We talk about what would you be willing to do, using that motivational interviewing style. So tell me, what would you be willing to do to change? What tools could help you manage this more? Eliciting those things, posing the questions, making them open-ended questions, not closed-ended questions, not yes or no questions. Do I have a slide? I don't have a slide on this, but I'll say this right now. We do a lot of coaching around the pros and cons technique. So what do you like about your marijuana use? What are some of the benefits of that? On the one hand, you say, and then the person will hopefully tell you, I enjoy unwinding, it helps me relax, blah, blah, blah. What are some of the not so positive, side to marijuana use? Well, it's illegal, I'm always chasing the substance. I never know when I can get it again, blah, 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 blah. So you do a little pro-con balance with them to elicit, what is it about their use that's the person making that use problematic for them potentially. So, and what they like about it too, so that you can help strategize with them what small change they can make around their use or big change. Some people might be willing to make a big change. More about, just brief intervention or brief advice. I talked about the terminology a few slides ago, but you don't just want to do this in a disrespectful way, offhanded, like, okay, I'm just going to do Sbirt. You have to genuinely really want to meet people where they are and give them the information that they're ready to take in. By establishing a rapport, building this motivation to change. I already mentioned this permission, asking permission, how that could improve somebody's self-confidence, show them respect, and open the door to a legitimate conversation. Because typically, people are not used to being approached in a respectful manner around substance use. What is it that makes you want to use your pain medication 3 times, more than the doctor recommended? Can I talk about that with you for a moment? Asking them that question to gain their permission. That all builds a rapport, and it opens the door for people to be willing to hear what the risk levels are. And then this slide talks about using summary statements as a way to engage patients. So this is where you are today. You came in, with problems sleeping. And you said you were drinking wine 5 nights a week, and we agree that wine sometimes doesn't actually help us sleep a full night's sleep. So what you're willing to do today is cut back to 4, and then when you come in next month, we'll see, does that one night sleep make it any better for you? And then affirm their ability to do this. So this is just meant to say, in a brief intervention technique, you can use review statements and summary statements. You can use pros and cons. You can use the readiness ruler. Pose open-ended questions, not close-ended questions. Those are all techniques that would be part of the brief intervention. Now, before I get on the referral to treatment, let me do a check-in with you guys and see what's going on.
We're still doing fine, Holly.
Good, good, good. Okay, we still have our audience. You guys are really plugging away. All right. Referral to treatment. Somebody did have a couple questions on that, and I started to say it's really local. And I think you have to come out with that frame of reference. But there has to be a little bit of legwork done if you're going to implement Sbirt on your half, and you have to have real meaningful referral sources. So that might mean to get an executive director to call an executive director of an agency that you don't normally collaborate with and say, if I am a mental health clinic doing screening and I uncover somebody who's willing and needs for their assessment, how long is their wait going to be? Are you going to be able to take my patient? What's it like? What are we supposed to do? Who are we supposed to call? You have to make those connections. And in our experience over the years, it has to be a local connection to referral to treatment. So it has to be in your area, in your region. So you do have to know what those resources are and maybe some of their limits. You have to know, are there waiting lists? If there are waiting lists, I was just in a rural part of New York, and they're like, there's waiting lists here for opiate treatment. And we were like, okay, well, what could we do with that? What could you do in your this is a primary care setting, talking to us, to help that? Well, they're like, well, we can engage in these continual conversations when they come in the primary care clinic to keep their motivation going until they can get in for treatment. But you have to know the reality of what you're referring into treatment. That can only be done by knowing what the local environment is. So that being said, well, let me say one more thing before I move on. We talk about a warm handoff versus a cold handoff in Sbirt. I guess you could probably figure out what that means. We want to know for sure that when you're handing a patient off for further referral for assessment and treatment, but possible treatment, but further assessment for sure, that it's real, it's warm, it's not just phone numbers. Now, that being said, there are certain circumstances and situations in which you are just going to be giving them further information. You can't help but do a cool or cold handoff. the worst thing is not to have any knowledge about where to refer anybody, whether it's warm or cold. So that being said, I'm going to show you a little technique that we've done. We're here, actually, we're housed in Pittsburgh, Pennsylvania, but we represent, the ATTC represents New York and Pennsylvania. So for this one project, we say, locally there are these county resources called Where to Turn. And in Allegheny County, they have a directory of mental health and drug and alcohol services. So there's a website, you know, but we get more specific than this slide shows. For some of the ER projects that we have going for Sbirt, we have the referral to the unit that they would go to within the healthcare setting, the system. We have a referral to some of the community providers that are blocks away from the ER department, and then we have a larger, you know, service provider setting that we can say here. We have a toll-free number that we have on a business card, and we clip it to their discharge sheets that they could call a hotline that's 24/7 staff. So we get to that local area of where people can turn to. I don't know if Allegheny County has the copyright on Where to Turn. I personally like the concept of where do you turn. You know, you might get the juices started and somebody's thinking in their home and they're like, you know what, I can't take it anymore. I got to have change. I'm ready. I'm willing. I'm ready. They have to know where to turn. So you have to make those connections local. Now, we also have, you know, we went up here. You can see we have the United Way in Southwest Pennsylvania. And then we also give them resources to 12-Step. If it's family members, you know, we have Al-Anon and Alateen, and we have the Narcotics Anonymous, and then some faith-based groups. But whatever, you know, you have to do your homework and know your local resources. You also really need to look at what's the warmest handoff I can give if somebody is ready, because, you know, hopefully you're motivating them to change and then they're ready to take that step if it's necessary. All right, on that note, let's go to reimbursement. I think somebody asked a question about that. And I know the slide, I don't know, the chart didn't come out that great. But SAMHSA has this on their website. Another website that's very good is called Insuring Alcohol Solutions. These are the current codes that are on. These are federal Medicaid, you know, H and G codes. I think the 15% of healthcare providers that are on the call will know these codes, and also the mental health and addictions professionals. So you guys know the codes too. But these codes are activated, and these are the reimbursement rates. I do know that probably sounds very low. We've heard from primary care or medical practices that this reimbursement rate is not the highest, that they can be reimbursed at a higher rate to do a different screen. But I challenge them a little bit to say, well, maybe you don't want your docs doing the screen, but maybe you need to put it somewhere else in the system that you could show you're doing the screen. The results of the screen can be put into the, you know, the moment that they're seeing the physician or the nursing assistant or somebody's giving them feedback, and that it's billable. And there, you might actually generate costs you didn't have coming into your system. And then, excuse me, the commercial insurance, you can see the CPT codes. Those are on, and many insurance agencies, not all, but there are the national insurers that are reimbursing. Again, we realize they are not highest for some other services that can be implemented, but they are on. There's some, New York State has their Medicaid codes on, as you know. That's why we had to give our little spiel about this training is not service that requirement. In Pennsylvania, I do know they do not have their state codes on yet. But the federal codes are on. And as I mentioned at the very beginning, I do know of Sbirt providers that are local to Pennsylvania that are, I called them up and I said, oh, are you guys doing Sbirt after the federal funding is done? And they're like, yeah, we have this system. We do it annually on anybody who comes into the clinic routinely. And if it's a new patient, they get it at intake. And then we bill for it. Okay. Sorry, I had a cold. I have a little bit of a cough, so I had some water. But thank you. They say, I don't even know. They're like, looked at me like I was a crazy woman. They're like, why are you even asking? And then we just send it to our billing department. She bills on it, Holly. I said, well, you guys don't realize that you actually have systematized something that most people find formidable, and you've made it cost-effective for the clinic because you're doing it routinely. And, you know, they just routinized it. They put the screen in for new patients at intake. For those who need it annually, they do it every year, and they follow up. So we can send you that link to SAMHSA's website as well. This is a good time to launch the last poll question. So Chris, if you want to go ahead. Chris, as I'm having my coughing attack, can you read the poll question?
The poll is now open for you to give your answers. Do you see your agency using Sbirt? And the options are yes, no, and maybe. And we'd like to see you all participate in this. So we're up to 71%. We'll let it go a little bit longer. Okay, I think that's, we're up to 75. We'll share this now. As you can see, this is good news. 68% say yes, they do see their agency using Sbirt. 20% no, and 12% maybe. So
let me use.
You're doing good there, Holly.
Let me use the motivational reading technique. We can ask those who said no, what would it take for you to use Sbirt? Maybe you want to throw that into the chat box or the question box as we finish up here. For those of you who said maybe, what would it take you to actually implement Sbirt? Is it higher? I mean, this is pie in the sky. We could just say, really, honestly, what would it take you to do Sbirt? More practice, higher reimbursement rate, etc. We do know for a fact that it seems so simple. It's a public health model. This is actually an evidence-based practice. It's one of those practices that you can embed in your system. If you're trying to do an evidence-based practice like cognitive behavioral therapy or motivational interviewing, you know that there's steps you have to take to be proficient in those. After this, you can really watch an Sbirt webinar, look at some of the screens, and you could try to do it. You can take these skills and try to do it. But we do know this. A lot of agencies can't sustain it once the grant funding goes away. So we do wonder, it seems so good on paper, why can't we do it? What is it going to take for us to actually do it? So maybe some of you have been thinking about that, and you can put that in your chat. And we can unmute people, and you can talk. You just need to raise that little yellow hand, click on it, and your hand will be raised. We'll unmute you. If we found in past, if we unmute everybody, we'll get background noise. So we do ask if you raise your hand, we can unmute you. You can tell us your thoughts and reflections. Let's see, I see some are coming in. Let me read some of these out here. Well, okay, that's so true. As a drug and alcohol provider, you wouldn't use it because we've already aware of the problem exists. That's true. You guys are on the other end of the spectrum, though. So for those of you, I would invite you, I think the first poll question, let me see, showed us that 38% or 27% of you were from the addictions field, to reach out and be that warm referral to the 38% on this webinar that are mental health clinics. So if they're doing Sbirt and they start asking their mental health patients with drug and alcohol screens if they have issues around drug and alcohol, that you would be that warm handoff. So that is one thing you guys can do as an addiction provider. But that is very true. You are already seeing people who have been diagnosed and are seeking treatment. On the other end, you can make collaboration. Somebody did ask about how to integrate community and substance abuse prevention. that's the continuum of care. You can make collaborations with healthcare providers and say, let us be your warm handoff. Also, what people are doing in other settings around the country is actually having addictions counselors in their behavioral health or medical health setting, having them do the screen and brief intervention, or follow up with just a brief intervention. They do the screen, they routinize the screen and somehow intake. But if somebody screens in a hazardous or harmful zone, those people are available and ready to give that intervention. So the flip side of that is, as I said, this is an intervention that's hard for people who are only working with those who have addictions, because it's hard for us to see that people in the risky use can make changes easily. So it's a double-edged sword. Somebody said maybe increasing referral sources and investment from state system to provide training, both on Sbirt but also on how to set it up within a business model. So true. In fact, when we do contract work on Sbirt, we do a business process analysis. Because this is not just for Sbirt, it's for anything we want to change in a system, anything we need to do new. We have to really try to look at how it's going to affect our system. It's going to, or else we're going to not be prepared for the barriers that come along in implementing anything new. Somebody said time involved and the lack of resources available for referral. Our treatment system, there are those who've probably seen them out on other webinars talking about, look, if everybody did Sbirt every time, universal Sbirt everywhere, we got what we hoped for. Our treatment system cannot take those millions of people that I mentioned several slides ago. That is true. We have to confront that and look at other strategies of keeping them engaged so that they can get treatment, or we need to expand our treatment system. I mean, maybe I can be radical here. We're pie in the sky right now. People present other issues or concerns not connected. Oh, we talked about that. Good, good, good. It's true. I mean, that's why we want to move on. If people are presenting and then you decide to do a screen and you're giving them that feedback, that we have to say, we have to keep our mind on their presenting condition for the setting that they're in. If you're doing Sbirt, we just did Sbirt training for 45 school counselors for the middle school and high school level. 2-day Sbirt training. And they were all very proficient in motivational interviewing. And so we were like, okay, you're going to do Sbirt, you're going to use the craft or another screen. But really, you have to keep the focus on what was the presenting issue that brought the student into the office, what brought the patient into the OBGYN office or PCP. You just want to make their connection to the screen and their use patterns. Let me see what else we got. I think we addressed almost everything on the chat board. Chris, how about, did I miss anything outstanding?
No, I think you're up to date right now.
Okay, good. I mean, we're looking at 3:50, so I'm almost done here. I just, wanted to see what would it take you all to use it. And again, it is good news that we've convinced 68% of 36 people to use it. But I respect the 12% that said maybe and the 20% that said no, because it is hard. It looks good on paper, but it is hard to implement new changes routinely without maybe some upfront help and training money, as people mentioned. Also, just help looking at your business process. I guess that's what the Sbirt-funded projects did, is it infused money to upstart things. But we know the long-term commitment has to come from looking at it and having complete buy-in to it so that you do want to adopt it and find ways to free up resources, time, money, location, etc., to actually do it. Really, this is all I had after this. I mean, I just have my nice little cute animated guy here that says, do you have any more questions? And, we'll keep the line open for those who might. But if you have other questions, here's my information. As I mentioned, Christine will send a survey. I see there's a question, so I'm not hanging up yet. But those of you who want to go ahead, this is really, we've covered all the content. But we will send you a link to some of the resources I mentioned. I definitely want you, especially those who are in the contemplation, that 12% maybe, to look at these Sbirt videos and see if that would help you say yes and not maybe, and even the no's to look at these videos so you can see Sbirt in action, because that is, seeing is believing. You can get a feel for it. I was really very descriptive in telling you the components of Sbirt. So those links will be sent to you, as well as the PowerPoint slides, the link to the reimbursement codes, and anything else we can think. We'll communicate with you all on those. Chris, was there anything you wanted to say? Was there anything anybody wanted to say?
On weekend, those will probably go out on Monday, and I will also send them the link to this webinar since it is being recorded.
Yes, thank you all. Thanks for hanging in there Wednesday before Thanksgiving, and a happy Thanksgiving to everybody. That's all I have, Chris, so we can shut it down.
Okay.